So here we start the interactive session for KUB. This all is covered in your course. We have given you about 10 classes of KUB. Now what we will do, we will highlight some important points over here from this KUB. So first of all, what you have to do, you have to be very clear with anatomy. Anatomy is the backbone of ultrasound, and in our hair, in this kidney, we have discussed the anatomy, and you have to paste that anatomy in your mind. That's it. A quick recap that the right kidney is bit low lying as compared to the left kidney. So this left kidney is a bit high up due to the liver, which is over here on the right side. And this right kidney is, this left kidney is about roughly 1 centimeter more than the right kidney, which we already discussed in our classes. Now, the important thing from the anatomy is where is cortex, where is medulla, the central sinus. You have to be very clear. We have already discussed this in our class. Now here, this is the parenchyma. This is the parenchyma. This all is the parenchyma. Now in this parenchyma, what is in parenchyma? The cortex. Cortex is here. This is the cortex. This is the cortex. This is the cortex. Now, where are the pyramids? These are the pyramids. These are the pyramids. So this all cortex with these pyramids is parenchyma. Now, which will be more echogenic, this pyramid or this cortex? Of course, the cortex. But when you are seeing on ultrasound, what you are seeing, you may not always, if the patient is not very thin, you may not see these pyramids. But the point is, the overall echogenicity of this parenchyma, which is composed of cortex and these collecting system, that is the pyramids, is hypoechoic with respect to the central sinus, which is having fat, these nerves over there. Now, when we are talking of CMD, corticomedullary differentiation, what we are talking of? We are talking of this cortex and these pyramids. This is medulla. So this is the cortex over here. So pay attention to this anatomy over here. Where is cortex? Where are the pyramids? Which part is the medulla? Because when I am talking of corticomedullary differentiation, I am comparing the echogenicity of cortex and medulla. So if I see the collecting system, I mean these pyramids, then it means that the corticomedullary differentiation is there. But one more important point, what is over there? I am comparing the echogenicity of this parenchyma with liver, which is on the top, from left side, and from left side, from right side, and from left it will be the spleen. Then I can see whether the liver is echogenic or the kidney is diseased. Now, in normal, these two, liver and this parenchyma, they are almost equal in echogenicity. Almost, I'm using word almost equal in echogenicity. Now if, let me erase all this. Now this is the liver over here, and this is the kidney. In kidney, we are having the central part and this outer part. So the outer will be parenchyma, and parenchyma is composed of cortex and medulla. Now the point is, this liver is equal in echogenicity when I am comparing it with what? With parenchyma. Now, if liver is more in echogenicity, then it will be fatty liver. But if this parenchyma is more echogenic. Now see, if this is more echogenic, then there are two possibilities. What are those? Either liver has decreased in echogenicity, or this parenchyma has increased in echogenicity. This is how we can make out whether there is a renal parenchymal disease. This was the question which has been posted. Now, how we can make out? We have to compare the echogenicity of this liver with this parenchyma. But make a note over here. Maybe that liver has got decreased in echogenicity. Maybe that there is inflammation in liver. Why not a hepatitis? So take the history, see for the signs of hepatitis, and if there will be hepatitis, then it will look like this parenchyma is increased. Actually, this parenchyma is not increased, so unnecessary don't overdiagnose a renal parenchyma disease. So this all is possible when I know where is parenchyma, what are the components of parenchyma, and with what I have to compare the echogenicity. So these are the important points which is already discussed with you. So I am giving you a quick recap of all these things. Now, one more important point from this whatever we are discussing right now. Now, if there is a small calculus, now see, people are confused whether this is a small calculus or a calcification. That is why these small calculus are overdiagnosed. If there's a big calculus, a 6 mm, 7 mm calculus, maybe a 10 mm, that is not a problem. But the problem is with small calculus, that is these concretions. Whether they are concretion, they are small calculus, or they are calcifications, or even a cross-cutted vessel. Now see how this anatomy, whatever we have discussed in last 2 minutes only. Now see how important that is. Now if there is a calculus, where will be the calculus? I'm giving you the options. You have to post in the comment box. You have to post in the comment box. Where will be the calculus? Will calculus be in cortex, or somewhere in medulla or collecting system? So the question is, are calculus in cortex or in medulla or collecting system? Post in the comment boxes now. Sultan, show me the comment box. Now, this is the cortex.
Collecting system.
Now see, this is the cortex. These are the pyramids over here. I'm giving an example of one small example of how important this anatomy is in ultrasound. Now, what I can see in the comment boxes, in collecting system, in collecting system, in collecting system. So I got about a 10, more than 10 right answers. Now implement this on ultrasound. Now see how. If you see a hyperechoic dot-like structure over here. Now, where I'm drawing right now? In cortex. So if you see a hyperechoic dot in a cortex, in an area of cortex, will that be a calculus? Or if this dot will be somewhere in the collecting system, that is near pyramids or in collecting system itself. Now, you better know that this cannot be a calculus over here, because the location is telling me that this is in cortex, and in cortex, why a small calculus should be in cortex? Now, what this can be is a calcification. Yes, why not a calcification? But this even can be a vessel, a small vessel. But you might be thinking, why a vessel is not doing like a vessel? Because maybe that you are cutting this vessel transversely, I mean in cross section. And if you are cutting this in cross section, it will look like a small calculus. Now see how important this anatomy is. If you know that this is cortex and you are seeing a dot-like structure, a hyperechoic circular or an oval, this can be a small calculus, or this can be a cross-cutted vessel, or even a calcification. Now the important point is the location. If it is in cortex, then it cannot be a calculus, and if it is in collecting system, yes, this can be a calculus. Now, how to see whether it is a cross-cutted vessel? Zoom onto that image. Zoom onto that image. Before that, what you have to do, you have to do all settings of the machine, whatever is discussed with you. You have to see for the frequency, you have to see for the dynamic range, you have to see for the focal zone, you have to see for the depth, then zoom. So zoom is the last option. And on zooming, you will see that these are actually two parallel dots, because this is actually a vessel. And if it is a vessel cutted in cross section, it will give you a parallel sign. So now the basic important point is, if I don't know anatomy, I cannot make out all these things. Now, if this is a calculus, there are high chances, about a 98% of chances, that this pyramid will be dilated. So if you see a proximal dilatation of a pyramid, that is confirming me that this small is a calculus, because the pyramid is dilated. Now see again how important the anatomy is. So know your anatomy, know your anatomy, and know your anatomy. And what I will suggest to you, to go back to the classes and go to the first class. That is very, very important for this understanding the Sono anatomy. We call it Sono anatomy. Yeah, what are the more important points? The kidney length. How much is the kidney length? Kidney length is in between 9 to 11. No, 9 to 14 centimeters. Now it depends on whether I am dealing with a short stature patient, or the habitus of that patient is very big. If I am scanning a Chinese patient, I will not expect a 13 or a 14 centimeters length. So if I am scanning a South African nigger, then yes, 14 is the limit. So this is the point, that it is in the range of 9 to 14, and the left kidney is 1 centimeter more than the right one. So the right one will be about 8 to 13 centimeters. So this is for a right kidney, and this is for the left kidney. So not only one, sometimes it can be up to 2. So 2 is the limit. 2 is the limit. On an average, it is 1 centimeter. the discrepancy of 1 is accepted, but it should not cross 2. In between 1 and 2, it is borderline. Now, how much is the width? Width is about 4 to 6 centimeters. So width is up to 6 centimeters. So 4 to 6 centimeters is the width. So will be the depth also. Depth and width here is same. So the depth and width, this is depth and width, and this is the length of the kidney. Okay. Now about the renal parenchymal echogenicity, we will discuss again, because this is very, very, very important. Now, classification of the renal parenchymal echogenicity, we have discussed this in class. I am repeating because this is very, very important. There are 4 types of ultrasound based appearance. 4, total of 4. We start from grade 0. What is in grade 0? Hypoechoic. Hypoechoic. Which one? Renal parenchyma. So the renal parenchyma, let me take another color. Renal parenchyma, I will write in short, is hypoechoic. Now see, hypoechoic. Compared to what? Compared to liver. Compared to liver. So I am comparing here with liver. Please try to draw this in your notebooks. Compared with liver. So when I'm comparing it with liver, what I'm comparing the renal parenchyma. It is hypoechoic, hypoechoic. That is grade 0. Now, grade 1. Grade first. Grade first is when it is isoechoic. Isoechoic. It means both liver as well as the renal parenchyma, they are equal. So that is grade 1. Now the grade second. Grade second is when it is hyperechoic. Hyperechoic compared to what? Compared to liver. When it is hyperechoic. What is hyperechoic? Renal parenchyma. Now see, the central point is the renal parenchyma. I am comparing it with the renal parenchyma. When the renal parenchyma is hyperechoic, that will be grade second. Now grade third. Grade third will be when it is isoechoic to renal sinus. It means that in grade third, it has increased so much that it is not only hyperechoic when I am comparing it with the liver, but it is more echoic, that the echogenicity is coming at par with the central sinus, which is the most echogenic part of the kidney. That is grade third. Now, which is normal? Grade 1 and grade second, they are normal. That is why I started with that the renal echogenicity can be at par with the liver, but it should not be more than the liver. So more than the liver will be grade second, and very high echogenic, that is when it is coming at par with the renal sinus. Grade third, of course, is abnormal. So grade 0 and grade 1, they are normal. Grade second and grade third, they are abnormal. So this way, you can grade the renal parenchymal echogenicity. So this is covered in your class. What I will suggest you to go back to that class for revision purposes, because this is very important point over here. Now, one more important point. You should know what I can see in kidney. Anatomical variants, I mean. This is very, very important because some anatomical variants will mimic like mass or some abnormality over here. Now, if I know that this thing can be seen in a normal kidney, then I will not overdiagnose a case. This is the point. So you should know the common anatomical variants. Let us revise this because this is already again covered in your classes. Anatomical variants. So what will be the normal anatomical variants? I want to listen it from you. Please post in the comment boxes. This is very, very important. You should know that this thing can be seen in a normal patient, not an abnormality, but a normal anatomical variant. Please post in your comment boxes. I will have a look on your chat boxes. Dromedary hump, yes, dromedary hump. Dromedary hump, horseshoe kidney, yes, horseshoe kidney also. Yes, 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 keep on posting, then only I will write it on whiteboard. Persistent fetal lobulations, very good. Persistent fetal lobulations, yes. One more is missing, ectopic kidney, yes, ectopic kidney. One more is missing, ectopic, fused ectopia, that is already covered. Lobulations is already done. One more. Persistent fetal lobulations, that is already covered. One more is left. Malrotated, yes. One more. Hypertrophied column of Burton, Dr. Sanjay, very good. So, yes, everybody, Dr. Premlata, Dr. Gupta, Dr. Asha, Dr. Chaksudeep, Dr. Pankaj Gupta and others. Yes, you have hit it right. Now let us write it so that we can memorize it. Now see, writing is, we are memorizing, our brain is memorizing whenever you will write. So why I am writing? I have memorized all this. I want you to write. So first of all, the atrophic small kidney. This is also normal. Atrophic small kidney. So it is not actually atrophic, it is small by birth. So small kidney, so it will be the first thing. Then the horseshoe kidney. Horseshoe kidney. Then cross-fused ectopia. But before that, let me write ectopic. Ectopic kidney. Then cross-fused ectopia. Then unilateral renal agenesis. Unilateral renal agenesis. I am writing in short. Then dromedary hump. Dromedary hump. Persistent fetal lobulations. Then prominent column of Burton. And the last, which everybody skipped, I don't know whether you skipped it or not, junctional parenchymal defect. Junctional parenchymal defect. Junctional parenchymal defect. You are missing this. So these are the points which I have to keep here in my mind, that this can be seen in a normal patient. This is a anatomical variant. Now, if I don't know that there is a dromedary hump and how to differentiate that dromedary hump from a mass, then I will easily label that there is a mass, but actually that will be a dromedary hump. How to differentiate, that is already covered in your course. And now see, if I don't know that there is something called as persistent fetal lobulations, I will easily make a diagnosis of some these abnormalities over there. So these are the important part. How to differentiate, we have already discussed in the class. What I will suggest you to go back to the class, revise it once more, so that it will keep in your mind for a longer period of time. Now, abnormalities, common pathologies. So these are the common abnormalities. Now the pathologies. Now the common pathologies. First of all, the favorite of all, calculus. Then renal cysts. And these can be cortical, these can be parapelvic, there can be cysts. Then renal infections. These pyelonephrites, etc. Then there can be the renal carcinoma. And what else? There can be polycystic kidney. Polycystic kidney. Now, these are the abnormalities. These are the common pathologies which you can see in the kidney. And this is already discussed in great detail in your course. Now, let me put one question. I will see whether you are memorizing whatever is taught to you in the classes. How I can make a diagnosis of this horseshoe kidney. Horseshoe kidney. Can I make a diagnosis, perfect diagnosis of horseshoe kidney in cross section or in long section? So I'm giving you a hint that the fusion is at lower pole. And if fusion is at lower pole, how can I make a diagnosis of horseshoe kidney? Should I go for cross section, I mean the transverse section, or the long section, I mean the length of kidney? In your comment boxes now. Sultan. Cross section. Dr. Asha, Dr. Pankaj, Dr. Sanjay, Dr. Premlata, Dr. Kailash Prasad, and others. Very good. Cross section, because in cross section only I can see two kidneys and I can see this connecting bridge. And in exams, what can be the this can be the question, or other way the question can be put: where is the fusion? Is that lower or at mid or at upper pole? You know that it is the fusion at the lower pole. So very good. It means that you have gone through the classes, you have completed your classes very nicely. Now, one more question. Not cross prosectopia, this extrarenal pelvis. Extrarenal pelvis, which is again a normal finding. This is kidney. This is the extrarenal pelvis. Now, if you see this extrarenal pelvis, the term itself, where it is, you know now. On ultrasound, it can look like a hydronephrosis or a hydroureter. Not hydronephrosis, it will look like a hydroureter. Question: how to make a diagnosis of extrarenal pelvis and not a hydroureter? Because it will very easily look like a hydroureter. It will of course look like a hydroureter, and if you don't know that This is an extrarenal pelvis. You will easily label this as hydroureter with a query calculus, because you are scanning here and there, you are not getting a calculus, and you will never get a calculus because this is not due to the obstruction. It is not due to the calculus, which is that this ureter is dilated, but this is not actually the ureter also. This is the pelvis, which is not inside kidney but outside kidney. Now, how can I think on lines of extrarenal pelvis? First of all, if now see, you have to think more when you are doing ultrasound. Time and again, I am telling this point. You have to think more and you have to see less. You don't have to see only. This is the point. Now, if this is a hydroureter, now see, if this is a hydroureter, why there is no hydronephrosis? This is a very important point. So, hydroureter, if any, there has to be a hydronephrosis. And if you are seeing this type of picture, you have to ask question to yourself, why there is no hydronephrosis? Why there is no hydronephrosis? Now, Sultan, fast, charge. Now, this is very important point, because if there is hydroureter, there has to be hydronephrosis. So a missing hydronephrosis is giving me a clue that I am dealing with an extrarenal pelvis. So, dromedary hump, persistent fetal lobulations, junctional fold. This is covered in great detail in your classes. What else we can discuss over here? Yes, these ureter calculi. Ureter calculi. There is one point which I will give you, the this color box. Whenever you are putting a color box on a ureter calculus, there is an artifact which is a twinkle artifact. We have showed you some patients also of this twinkle artifact. In your courses, we have showed you. Now, this is the ureter over here. If you are suspecting that there is a calculus, but you cannot make out this calculus very clearly, then put a color box onto this area on a suspected calculus, and if it shows you, I'm using word if, not always, if it shows you a twinkle artifact, it has to be 100% ureter calculus. So not all ureter calculi will show you the twinkle artifact, but more than 95% of ureter calculi are giving me this twinkle artifact, and this is a very beautiful sign to confirm that the above structure is the ureter calculus itself. So now what I can do, I can turn the table around. If I am searching for a calculus, why not to take this color box and why not to put it on the lower ureter area, I mean at UVJ? Why not to drag this slight movement of this upwards, and if at any point it is giving me this twinkle artifact, then why not to trace from that twinkle artifact, and that twinkle artifact will take me to the ureter calculus. So you can try this in your patients. Now, hydronephrosis, there are these gradings of hydronephrosis, grade 1, 2, 3, 4, how to grade it. We have discussed it. We have to see for the collecting systems how they are looking like, whether they are T, whether they are looking like O, whether they are looking like a Y. Accordingly, you can grade it, grade first, second, third, and very severe. And in very severe, there has to be the cortical thickness, thinning of the cortex also. So there should be a very thin cortex. So that is already covered. We will not repeat it. What I will suggest you to go to the class videos for revision purposes. Now, hydronephrosis. Now, as we have touched it, the hydronephrosis can be confused with renal cysts, especially multiple renal cysts can be confused with hydronephrosis. So C for the communication. Now, if this is a hydronephrosis, if now see, this will look like a cyst. If this is a hydronephrosis, you have to see for the communication, and these will communicate. And in case of the renal cyst, the cysts are not having any communications. So then the renal this nephrocalcinosis. Nephrocalcinosis. There are two types of nephrocalcinosis. One is the cortical nephrocalcinosis, then another is the medullary nephrocalcinosis. Whenever these collecting systems looks very echogenic, or the cortex looks very echogenic, accordingly you can say whether it is cortical nephrocalcinosis or the medullary nephrocalcinosis. Now the renal cysts. This is a very, very big topic. We cannot revise whole of the renal cysts over here. I think that we have given you 1.5 hours class on this renal cyst, how to make a diagnosis of adult dominant polycystic kidney, adult recessive infantile polycystic kidney, and the multicystic kidney. This is very important because you have to differentiate, you have to label whether I am dealing with ADPCKD or ARPCKD or a multicystic kidney. Go to that class. That is a very lengthy class. It is about 1.5 or maybe, but it is more than 1 hour. It is more than 1 hour class on of this renal cyst differentiation. So what is left now from kidney? Pyelonephritis. Now in pyelonephritis, the kidney, how the kidney will be in pyelonephritis? Kidney, first of all, the kidney echogenicity. Now see the renal echogenicity. We will not expect it to increase, but it will decrease, because the inflammation rule of the inflammation is that wherever there is inflammation, the echogenicity has to drop. And what will be the length of the kidney or the width of the kidney? Increased, increased, and increased. And there will be the tenderness, and these are the findings of pyelonephritis. Now there can be a focal pyelonephritis also. Keep that point in mind, because that will look like a mass. That will look like a mass. So there is something which is called as focal pyelonephritis. Now what is left? Renal abscesses. Renal abscesses looks, the abscess looks same, be it in liver, be it in this kidney, be it in spleen. There are phases of abscess. The abscesses don't have clear contours, irregular contours, and towards the end the echogenicity drops. Everything, the concept of the abscess is same. Whatever is discussed with you, yes, there can be the renal abscesses also. Okay, so these are the important points what you have to remember from this kidney. Now from the this prostate. Now this is the bladder, and this is the prostate over here. The important point is, whenever I am taking the volume of anything, be it ovary, be it this bladder, be it prostate, I have to take 3 measurements. 3 measurements. We have discussed this in from physics. We have discussed it multiple times. 3 measurements. Now here I have to take the first measurement, because now I am in transverse section. Whenever I'm in transverse section, I will be taking width, and I can take the depth from here. But for length, I have to take the prostate in length. In length. Then only I can take the measurement over here. So don't take the measurement like this, the third measurement. No, this is wrong, wrong, and wrong. You have to take a long axis of the organ, then only you can take the measurements. And from this prostate, what you have to see in hypertrophy in medial, in this benign hypertrophy of prostate, what you have to see for any medial lobe hypertrophy. And if there will be any medial lobe hypertrophy, that will be bulging in the UB, and you have to measure this. You have to measure this median lobe separately. You have to measure this median lobe separately, and you have to report it. You have to give it in report that the median lobe is measuring this much. And what you have to do, you have to measure the full volume of the bladder, and you have to measure the post-void residual urine also. And one more important point, that there can be a cystic structure which is absolutely normal. There can be a cystic structure, small cystic structure in the prostate, that is absolutely normal if it is very small and clear echoes. So there can be a calcification. There can be a calcified foci in the prostate, and if there is a big calcified foci, then that patient, and we have to go for the prostatic specific antigen in that patient. Okay. So this was all about the highlights. This is not the whole of the class, whatever we are discussing. These are some of the highlights which you have to take in account when you are taking the kidney. So I will again suggest you to go to the class and revise these classes. So this is the beauty of these classes which we are providing, that you can easily go for the classes at any point of time. You can revise it. So if you have any question, you can post now in your comment section. Otherwise, we will take your leave. Okay.
How we can diagnose seminal irregularities?
So see how to diagnose a urethral calculus. Where is the urethra? You know it. You are not implementing it. Now you have to think yourself. You have to correlate the things. You know the anatomy. You know where is the urethra, and from there you have to trace for any dilatation, because maybe that you are dealing with a prostatic calcification and unnecessary. You are overdiagnosing a case. So whenever there is a urethral calculus, there has to be a dilatation. And if you see a hyperechoic dot only, that can be a prostatic calcification. So see for the dilatation of the urethra. So there has to be the proximal dilatation, and if there is a proximal dilatation of the urethra, then only you can make a diagnosis. Otherwise, please think on lines of the prostatic calcifications, because the two are looking same. And if there is a clear shadowing, then yes, that goes in favor of, but dilatation is more important. You can try the this color box. What to for? Maybe that it will show you a Twinkle Artifact. So everything putting in one basket, then only make a diagnosis. Otherwise, you may be overdiagnosing a case. Maybe that it is not a calculus actually, but maybe that there is a calcification. So this was all for now. See you next time. So one more question: normal post-void volume. Now see, the normal post-void volume is less than 10%, of the full bladder, So if the bladder is, for example, 500 cc, the post-void has to be less than 50. And if the full volume of the bladder is 30 cc, then the post-void residual urine has to be only 30. So less than I'm using word, less than 10% of the full volume of the bladder. That is why we are giving both full volume as well as the post-void residual urine. And you have to mention it in your report that the full volume urinary bladder was this much, and their post-void residual volume is this much, and you have to mention whether this is significant or not significant, and when you can how you can make it make a note that this is significant if it is more than 10%, and if it is less than 10%, then you can put in bracket that this is insignificant. No, it is not 25%. 25%. I am seeing the comment box. Somebody is posting that is it 25%. No, not 25%. Now see, if it is 25%, then if the full volume of the bladder is 300, maybe 400, let's take 300. Now you can calculate the 25% from 300. That will be approx 70 or maybe 80 cc. That is no, this is not 25%, but it is a cut is 10% of the full volume of the bladder. So no more questions. See you very soon. Thank you very much. God bless all of you. We will give you an update of any class if there is any interactive class in near future. I don't remember whether everything has been taken with you.